My name is Ambra Lorenz, and thank you for watching this presentation on my scholarly project titled Improving Patient Engagement in Fall Prevention Through Staff Education in Acute Care. I would like to thank my committee members for their help and contribution to my project, Dr. Maria Snell, Dr. Lisa Stewart, and Dr. Holly Fulbright. Their contributions have been invaluable to the completion of this project. Background and significance. This scholarly project is centered on reducing or eliminating postoperative falls in acute med-surg inpatient hospital units. Falls are considered largely preventable but remain a continuous source of poor outcomes in hospitalized patients despite all the efforts to eliminate them. Inpatient falls are associated with increased healthcare costs due to additional treatment and diagnostics as well as prolonged length of stay. Additionally, hospital falls have been associated with increased costs ranging from approximately $3,500 to over $14,000 per event, depending on the severity. Thus, even small reductions in fall incidents can yield meaningful cost savings. Total joint arthroplasty patients are at particularly high risk for falls after surgery because of anesthetic and pain medications, lower extremity nerve blocks administered preoperatively, comorbidities such as heart disease and hypertension, which are potentially exacerbated after surgery, and even a lack of understanding regarding their risk of falls and the morbidity associated with fall outcomes. For example, I've seen patients after total joint replacement who feel stable in bed but underestimate their fall risk when they first try to get up. Invariably, they get out of bed without calling for help, their knee buckles, and they go to the ground. This scholarly project aims to educate inpatient nurses and inform hospital policy regarding the necessity of targeted patient education and engagement in fall prevention. And that's important because given the current lack of high quality, well-designed, and well-delivered fall prevention education on the inpatient floor where this project took place, this project will help narrow the theory-practice gap. In practice, this means introducing a fall prevention education intervention designed using current literature and evidence to engage and educate the patient more thoroughly and to incorporate the why for all the fall prevention interventions in place. Review of the literature. The literature review aimed to evaluate the implementation of hospital fall prevention programs, the impact of fall prevention programs on fall rates, and the overarching impact of targeted patient education on fall rates through individualized patient engagement. For this integrated review of literature, the body of evidence on fall prevention in the hospital was examined, and 16 articles were chosen and categorized into 3 applicable themes. 1. Hospital fall prevention programs. 2. Fall prevention education. And 3. Improving patient outcomes through patient engagement. The literature supports the idea that multifactorial fall prevention interventions implemented in hospitals can reduce fall rates. These interventions range from fall risk assessment and scoring to low bed positioning, non-skid footwear, nightlight use, purposeful rounding, gait belts, and staff assistance for all patients out of bed all the time. Among the many fall prevention methodologies, patient and staff education is robustly supported in the literature as highly impactful on fall rates. Tailoring fall prevention education to the individual patient is supported by research as highly effective. Another critical aspect of patient education emerging from the literature is the concept of patient engagement. What stood out to me in the literature review is that while multifactorial interventions are widely used, patient education, especially when individualized, was one of the most consistently effective components of fall prevention efforts. Theoretical framework. The framework that provides the basis for answering the clinical question posited in this project is the patient engagement framework. It is credited in the research study that guided this project by Guo and colleagues in 2023. While there is no single author of this framework, it is present throughout the literature, and research has been dedicated to developing this theory. The World Health Organization in 2014 dedicated efforts to the development of this framework as part of its goal to reduce patient harm and healthcare costs through empowering patients and healthcare staff to deliver efficient, patient-centered, and high-quality healthcare to achieve the triple aim of improving health outcomes, improving patient experience, and improving per capita healthcare costs. The patient engagement framework includes 5 elements as described by Gua and his colleagues: informing, participation, empowerment, cooperation, and electronic information supports. Informing means giving patients clear information, but empowerment is taking it a step further, helping them understand why they are at risk. Eliciting patient participation is key to engaging them in conversation. This can be done by asking questions rather than just talking to them. For example, asking patients whether they have previously fallen and whether they are anxious about falling after surgery. Patient cooperation is essential. The inclusion of electronic information support has been shown to be increasingly impactful on patients' information absorption in this digital age and to further the patient's ability to fully engage in information exchange. The patient engagement framework aims to improve patient participation in the healthcare process. Patient engagement promotes patient involvement in healthcare decision-making. The patient engagement framework can occur in various settings, such as a healthcare organization's clinic or hospital, and there are various engagement behaviors a patient can participate in. For example, providers in a hospital setting routinely implement safety precautions to prevent patient harm, such as requiring patients to have staff assistance to get out of bed. These precautions require patient compliance to be fully effective, and engaging the patient in this education could help improve that compliance. Methods and design. This project utilized a quantitative, quasi-experimental pre-post intervention design. The independent variable was time, pre-intervention versus post-intervention, and the dependent variable was fall occurrence, yes or no. Randomization was not feasible in this clinical setting. However, this design enabled a structured evaluation of the intervention's impact. As a quality improvement initiative, the primary aim was to assess a practice change within a real-world clinical environment rather than to generalize findings broadly. The project was conducted on a postoperative orthopedic unit and included patients undergoing total joint arthroplasty. The total sample consisted of 312 patient encounters, with 156 in the pre-intervention group and 156 in the post-intervention group. Outcomes were measured by comparing fall rates, defined as the number of patients who experienced a fall divided by the total number of postoperative total joint patients between the pre-intervention, when they had standard fall education, and post-intervention, when they had the enhanced fall prevention education periods, to determine statistical significance. The intervention consisted of a nurse-delivered fall prevention education tool. Nurses received training on implementing tools, patient engagement strategies, and consistent documentation in the electronic medical record. The primary outcome measured was the occurrence of patient falls during each 4-week study period. The sample included 312 postoperative orthopedic patient encounters, with 156 in the pre-intervention group and 156 in the post-intervention group. All patients had undergone total joint arthroplasty, either knee or hip. A convenience sampling method was used, including all eligible patients admitted to the unit during 2 consecutive 4-week periods. Because this was a quality improvement project focused on unit-level outcomes, only aggregate data were collected and no demographic variables were included. Descriptively, the groups were equal in size, which supported a balanced comparison of fall rates before and after the intervention. Data analysis. Descriptive statistics were used to summarize fall occurrence among post-operative total joint replacement patients during the 4-week pre-intervention and 4-week post-intervention periods. To evaluate the intervention's effect, a lower-tailed z-test for the difference between two independent proportions was conducted to compare fall rates between the pre- and post-intervention groups. This test was appropriate because the outcome variable, fall occurrence, was dichotomous and proportions were compared between two independent groups. A directional lower-tailed test was selected because the intervention was expected to reduce fall rates. The significance level was set at alpha equals 0.05. This analytic approach allowed for an objective evaluation of whether the intervention resulted in a statistically significant decrease in falls. Results. The results slide presents the key findings of the data analyses and the statistical tests used in the study, along with key findings of the statistical analyses and outcome measures. As shown in the figure, the pre-intervention fall rate was 1.28%, with 2 falls among 156 patients. In the post-intervention group, there were no falls, resulting in a 0% fall rate. While only 2 falls occurred pre-intervention, reducing that to 0 is important because even a single fall can result in significant morbidity for the patient's outcomes. This shows a decrease in falls following implementation of the educational tool. However, the statistical analysis yielded a z-score of minus 1.42 and a p-value of 0.078. Because the p-value is greater than the alpha level of 0.05, the null hypothesis was not rejected and the result did not reach statistical significance. This is likely influenced by the low baseline fall rate and limited sample size, which reduced statistical power. Even though statistical significance was not achieved, the reduction to 0 falls may still be clinically meaningful and suggest the intervention has potential benefit. Limitations. Some limitations of this project were the small sample size and very low number of fall events, which limited statistical power and the ability to detect a significant difference. Because falls are rare events, a small sample size makes it much harder to detect statistical significance. The data collection period was also relatively short, with only 2 4-week intervals. Additionally, the study was conducted within a single orthopedic population, which may limit generalizability to other patient populations and care settings. Because this was a quasi-experimental design, there was no randomization or control group, which limits the ability to establish causality. Also, no demographic data were collected, so I was unable to assess whether the groups were fully comparable. Finally, there may have been some variability in how consistently staff implemented the education tool, which could have influenced the results. Despite these limitations, the intervention demonstrates strong potential for sustainability and scalability across other inpatient units, including medical, surgical, and rehabilitation settings, where patients face similar mobility and safety risks. The education involved in this project, along with the visual tool used in conjunction with it, illustrates the patient's risks related to these factors. Discussion. The purpose of this project was to determine whether a structured nurse-delivered fall prevention education tool could reduce falls in postoperative orthopedic patients. The results showed a decrease in fall rate from 1.28% to 0% after implementation. While this was not statistically significant, it may still be clinically meaningful, especially given that falls are high-risk, low-frequency events. These findings suggest that the intervention has the potential to improve patient safety and support fall prevention efforts. They are consistent with existing literature, which shows that patient education plays a key role in fall prevention. Additionally, staff must be educated on proven methods for educating patients, fostering high uptake of the information, better patient understanding, and as a result, greater compliance. The lack of statistical significance is likely related to the low baseline fall rate and limited sample size, which reduced the study's power. Overall, the results support the research question by indicating that the education tool may be beneficial, but further evaluation with a larger sample size and longer time frame is needed. Implications for practice. This project supports the use of a standardized fall prevention education tool in postoperative orthopedic patients. It highlights the importance of patient engagement and ensuring patients understand their role in preventing falls. From a nursing perspective, it reinforces our role in delivering consistent, effective education as part of our routine care. As a future advanced practice nurse, this reinforces my role not only in patient care, but in leading system-level quality improvement initiatives. Even though statistical significance was not achieved, reducing falls has important implications for patient safety, outcomes, and healthcare costs. This intervention is also easily scalable and could be implemented in other units or patient populations to further support fall prevention efforts. This quality improvement project advances nursing practice by informing evidence-based practice changes for nurses caring for patients in the acute care setting by incorporating patient engagement in fall prevention education. Nurses play a critical role in identifying fall risk, delivering high-quality targeted education to patients at high risk of falls, and promoting adherence to safety interventions in the acute care setting. The findings underscore the importance of evidence-based practice in improving patient outcomes and highlights nurses' role in quality improvement initiatives. By incorporating structured, patient-centered education, nurses can enhance patient understanding, engagement, and participation in fall prevention strategies. This project also emphasizes the role of advanced practice nurses in leading system-level quality improvement initiatives that translate evidence into practice, improving care processes, and promoting a culture of safety. Interdisciplinary collaboration and communication among healthcare team members further support improved patient outcomes and reinforce shared accountability for patient safety. Conclusions. This quality improvement project evaluated the implementation of a structured nurse-delivered fall prevention education tool on a postoperative orthopedic unit. While the intervention was associated with a reduction in fall incidence from the pre-intervention period to the post-intervention period, the results did not reach statistical significance. These findings suggest that although an intervention shows promise, the infrequent falls and limited sample size may have reduced the ability to detect a statistically significant difference. Despite this, the absence of falls in the post-intervention period is clinically meaningful and supports continued emphasis on patient-centered fall prevention strategies. From a practice perspective, this project improved consistency in patient education, increased nursing awareness of fall risk, and enhanced documentation practices in the electronic medical record. These changes represent meaningful improvements in care processes, even in the absence of statistically significant outcomes. The project reinforces the importance of integrating structured education into routine nursing workflows, particularly in high-risk postoperative populations. If this project were to be repeated, several modifications would be considered. Extending the data collection period and increasing the sample size would improve statistical power and the ability to detect significant differences. Additionally, incorporating patient-level variables and compliance tracking with the education tool could provide deeper insight into factors influencing fall outcomes. Ongoing staff reinforcement and auditing may also strengthen intervention fidelity. Future plans include sustaining the use of the fall prevention education tool and exploring opportunities to expand its implementation to other surgical populations. Further evaluation over a longer time frame may help determine the intervention's long-term impact. There is also potential to disseminate these findings through presentation or publication to contribute to the broader body of evidence supporting fall prevention strategies in orthopedic settings. The DNP program has had a significant impact on my professional development, strengthening my ability to critically evaluate evidence, apply research to practice, and lead quality improvement initiatives. Through this process, I have developed skills in data analysis, project implementation, and interdisciplinary collaboration. I have also gained a deeper understanding of the challenges of translating evidence into practice in complex healthcare systems. Overall, this experience has enhanced my confidence as a nurse leader and prepared me to continue driving practice improvements that positively impact patient outcomes. The following slides are my references for this project. Thank you for watching.